Dear colleagues, welcome. I welcome you to the 6th Clinical Trials Masterclass. Before introducing our exceptional guest today, I would love to introduce my co-host today, who is Janine Pöss. Janine is an interventional cardiologist and intensive care specialist at the Leipzig Heart Center in Germany. She has worked with Holger Thiele, who we have heard on our channel too, in several departments and has a long-standing experience in critical care clinical trials. Janine is the current head of the ICU at the Leipzig Heart Center. So she's already involved in all topics we are going to discuss today on a day-to-day basis. She has also collaborated with our guest today within the framework of the Critical Care Clinical Trialist workshop, which will be discussed today too. Dear Janine, thank you very much for joining us. Thank you for taking your time.
Thank you very much, David, for the introduction and for the invitation to be here at this great lecture. And it's my great pleasure to announce Professor Alexandre Mebazaa, who is the chair of the Department of Anesthesiology and Critical Care at the Hôpital Lariboisière in Paris. He acted as a member or chair of several steering committees and is involved in the several European and global registries on circulatory failure. As most of you will know, he has authored more than 300 papers and is co-author of the latest heart failure guidelines by the ESC. So an absolute expert in the field. And Alexandre, we are very much looking forward to your lecture.
Thank you so much, Janine. Thank you, David. I'm going to, during my lecture, I'm going to show you some data that are very important for me, because every time we are called to design a new trial, I have many of those data in mind, and you will see that I hope during the discussion you will challenge me to say that you may agree or disagree. But what is interesting is many of the things I will show you, maybe all of the things I will tell you, are based on data. Okay, my first slide is going to be also my last slide, and I'm going to show you how designing a trial in critical care, it's a high number of challenges. It's not only one or two or three. One, we will discuss about selecting the patients, and we will talk about predictive way, other ways. I will also, and for me it's very, very important, is selection of the centers. I will show you some data. I hope that will convince you that you should highly select the centers before including them in trials, and not say, okay, I found 10 centers in that country, let's take them. Oh yeah, great. No, it's not as easy because 10 centers can kill your study. Selecting the endpoint. The endpoint is very important, and indeed the drug that you're putting or the procedure that you're testing needs to be actionable on the endpoint. The number of included cardiology, we are doing critical care. Sometimes you to do large trial, but there is an unnamed dilution effect, and I think you absolutely need to know what is this dilution effect. And maybe one of the tricks is I will advise you to do a survey prior to any trial. Let's start with acute heart failure, and you will see that I will jump from acute heart failure to trials in intensive care. But really, I was happy to have those two backgrounds, the background in acute heart failure and running trials in acute heart failure, and also critical care, because really there is a lot of interdigitations. Acute heart failure, today what is advised is that within minutes of admission, we should triage the patient, whether there is a severity score, yes or no. Yes, the patient goes to the ICU. Then no, which is the majority of the cases. The patient should have a diagnostic test to confirm acute heart failure. And it is said in the guidelines that the patient should have IV therapy if the blood pressure is below 110, diuretics, more than 110, vasodilators or diuretics. And those guidelines, and you see this paper is one of my more referenced paper, is based in fact on nothing, because there is no data to support this. And maybe worse than that, acute heart failure is in fact a big bag, where the cause of decompensation of the heart, then the heart is suddenly not working properly, and there is a lot of blood staying upstream the ventricle, the left and the right ventricle. The left ventricle is pulmonary edema, the right ventricle is edema in the legs, jugular vein distension. The cause of decompensation of the heart, we all know, is could be multiple. It could be acute coronary syndrome, it could be infection. And in fact, what we did with Mattia Arrigo from Switzerland, we tried to see whether the moment that the patient died in the ICU, whether this is related to the cause of decompensation or not. And the answer is indeed yes. We looked on 3 causes of decompensation: acute coronary syndrome, infection, and atrial fibrillation. As you can see here, this is week 1, week 2, week 3, week 4. And then we have the following weeks here. First, you see that atrial fibrillation, in fact, the risk is much lower than the other cause, and then the risk to die from an atrial fibrillation related to acute heart failure is lower than the other cause. And despite this, atrial fibrillation is included in trials with acute heart failure, although it's not generating events. Then you already see that we are going to, by including or not excluding the patients with acute heart failure and atrial fibrillation, we are already understanding that we are going to put a noise in the bag, and we then reduce the chance of success for therapies. Now, if we look on acute coronary syndrome and infection, you see that the story is rather different. Here on the y-axis, again, we have the hazard ratio. When it goes up, it's a risk of mortality. And you see here that in patients coming with acute coronary syndrome, and those are patients for whom the intensivist or the emergency physician or the cardiologist put within minutes of admission, this patient came, or hours of admission, this patient came for acute coronary syndrome and acute heart failure. However, nothing was specially done to those patients, no cath lab, no special exams. And you see that those patients die rather with a high rate, or at least the risk of death is very high in the beginning, is decreasing over the following weeks. However, you see that patients coming with acute heart failure and infection, and again, those patients did not get antibiotics, although it's written infection, they die later, often when they go back home, and you see at week 3 and week 4, they die. Then you see that slowly, you see that parameters that are not put as inclusion or exclusion criteria often could be a main determinant. And you see here comorbidities. Comorbidities are going to slowly start to be an important parameter of death after acute heart failure. Then if you put your endpoint after, let's say, 2 months or 3 months, then you see that some death will be related to comorbidities. And again, how would you like to have a treatment giving here very early? How can it improve survival rate if some of the death between 1 and 2 months are related to some comorbidities that exist even before the acute heart failure episode? How are we going to try to select our patients? And this, we published this 2 years ago, is to show that there are two techniques. There is a classical technique named the Prognostic Enrichment, and another one that we are using more and more named Predictive Enrichment. Prognostic enrichment, you know this, is we select the patients with the highest risk of poor outcome. And we were doing this for 30 years. We were putting inclusion-exclusion criteria to have patients dying a lot. The only problem is you need to have patients with an actionable event. If the patient has a car accident and you're giving a vasodilator, it's not going to have any action. Then prognostic enrichment is very dangerous because you have patients with a high risk, but you are not sure that the high risk of death is related to the disease. to try to answer to this question of vasodilator, for example, and the cause of decompensation with this paper that was published 2 years ago, named the Elizabeth. I show you this because we used a step-wedge approach, and you will see why we did this. Then the bundles were the following. We were asking all the emergency physicians to do imaging, biomarkers, but we also said you need absolutely to treat, and indeed in the treated arm, you need to treat the cause, whether it's related to infection, acute coronary syndrome, or atrial fibrillation. And this is an important trial. Why? Because in the guided trial, we show that if you give a biomarker, it helps treating the patient. And here is the step-wedged approach. I'm sure many of you know this technique, but just to make sure that we are all on the same page. In fact, here you have to consider that there are all emergency rooms. And let's say here we have 5 emergency rooms. And then the week and all the emergency room have to start the protocol at the same time. And then we have, let's say, the emergency room 1 that was doing their usual procedure. And one Monday morning we call them, and now we say we go to the invasive techniques. Then by this technique, you have every emergency room where we have data from before the new procedure, example here, and in blue, the new invasive procedure. And this is important when you are changing the procedure. When we ask to treat a cause, you are changing the procedure, and then it's rather impossible the same morning in the same emergency room to have a patient A that is treated in a historical way and patient B that is treated by a new way. Then this is our design, 15 centers, and the patients and the centers were followed for 35 weeks. And at the end, we included 200 patients in one arm and 300 patients in the other arm. Did we succeed? The answer is yes. For example, here in the treated arm, we asked them to put a lot of nitrates, and they succeeded because after starting the new procedure, we had a median of 27 milligram IV vasodilators compared to 0 before. And it shows that you can write whatever guidelines you want. People are not following the guidelines because even with guidelines since many, many years, the median was 0 nitrates. And here we have to be aggressive in the treated arms, invasive arms. Bundles, yes, bundles were followed, not 100%, but better than before. And we can see that 59% of the patients, after changing the protocol, who were treated for their cause compared to 23 before. And again, it's incredible to know that although antibiotics are present in all the emergency rooms, contacting a cardiologist is not difficult. Only 1 patient over 4 has the appropriate treatment. The primary endpoint was the number of days alive and out of the hospital. And the results is no difference between the 2 arms, at least not statistically different differences, meaning that the treatment in the first 4 to 6 hours by giving a high dose of vasodilators and taking care of the bundles in the first hours does not influence the outcome. And this results was confirmed, at least concerning the vasodilators, was confirmed by Christian Müller and Galactic investigators. They had 2 arms, standard of care intervention with vasodilators giving by patch and oral therapies very aggressively. And here again, no difference at all in the first 180 days after admission for acute heart failure. And the primary endpoint was death or readmission for acute heart failure. Then, as I told you, when you are writing an inclusion-exclusion criteria, you try to select the patients. You always try to see how many events the selected patients can generate, But what is very important is to wonder whether those events are really actionable or not by the procedure or the treatment. The main problem we had to face in the last 30 years is in all the trials I was part on or I saw in the literature, the number of events in acute heart failure, or almost consistently, was always below the number of events that was expected by the investigators when they wrote the trial. And to try to understand why this, what we did with Antoine Kimoun, we did the largest meta-analysis ever done in the world. In fact, we looked on all the papers, all the trials, all the cohorts published between 1980 and 2017, then over 35 years, with more than 100 patients that had 30-day or 1 year all death and readmission, and to try to understand what is the time, the temporal trends of those two parameters over the last 35 years. Then this ended up with an impressive number of studies, 285, and maybe an even more impressive number of patients, 15 millions. And here is what we saw. Here on the top, we have mortality at 30 days, mortality at 1 year. And at the bottom, in a minute, I will tell you about readmission. Then mortality. And in fact, mortality, the results explains why the number of deaths were consistently always below what was expected by the investigators. It's because the 30 days mortality and 1 year mortality is decreasing over the last 35 years globally in the world. And interestingly, when we look by continent, Asia in green, Europe in red, and North America, we saw that those tendencies are present in almost all the studied continents. Now, surprisingly enough, and again, we can discuss this later, although there is a reduction in mortality, it's still high. I mean, we still have 10% at 30 days. See here, readmission rate. Readmission rate, we have almost no positive signs. You see that readmission rate, 30 days readmission rate, or even 1 year readmission rate. See here in Asia, in North America, we are close to 50% of acute heart failure patients that are readmitted within the year. The only exception is here, Europe, that is markedly decreasing. But overall, although we seems to have improved results in mortality, we still have a very high signals. You see here 20% at 30 days, 50% at 1 year, a high signal of readmission. Now, when we are designing a trial, usually when we put inclusion, exclusion criteria, you put age, you put things like this, but we never put gender, as we are getting male and female, and as you know, ESC and others association are saying that we should even balance more our trials to have 50% men and 50% women. And I think this is right. Why? Because the outcome is totally different between men and women. This is a study that was published 2 years ago with Justina Motiejūnaitė from Lithuania, that is now in Paris. And we collected national database and databases from a large part of the Northern Hemisphere. And guess what? See here, in many countries, you see that there is a statistical difference and the mortality is much lower in women compared to men. And this is again true for all the cohort, and this was especially true in few countries. Then you see that slowly, we are discovering that when we are putting inclusion, exclusion criteria, there are some parameters we are thinking about because it's going to change the number of events. There are classical parameters to select the number and enrich the number of events, but some parameters we never think about that can markedly change the number of events. It's gender, because if by chance there are more women or more men and you didn't plan this, indeed you will have more or less events. Another issue I would like to take few minutes to tell you about, and please keep this in mind because it's probably one of the most important parameters for me. It is the selection of the centers and the country. And you will see that in trials that are run from companies and they are contacting CROs, very often at some stage, you will say, oh, but we don't have enough centers, we don't have enough countries to run this trial, we need to find other countries and trials and centers. And then you have a CRO who said, no problem, I am working in that and that countries, and suddenly they give you a list of 20 centers and you are happy. In fact, I tell you, you should be rather very, very careful with centers and country that you do not know. Those are data that were given to me by courtesy by Gadi Cotter and Beth Davison, and those data were presented in our 3CT meeting. This is a meeting that is held every year in the French Embassy in Washington, DC. It's a critical care trial forum, and where we put together American and European trialists in critical care area together with NIH, EMEA, and FDA. And those data were just shocking when we saw them. What means those data? Here on the y-axis, you have the relative risk reduction in cardiovascular death. Here it is in RELAX 1, that was a first small study, and then RELAX 2, that was a large study. Here is the data by country. On the x-axis is the country quality score. What does it mean? It means that for heart failure, the guidelines are saying when the patient comes, you should do this. In the first hours, you should treat like this. In the first days, you should treat like this. Then you just put a series of parameters and you check whether in those countries, the majority of the patients being included in the trials, whether they had those parameters or they didn't have the parameter. And the more they had the parameter, the higher is the quality score. The less they had, it means that the less they well manage the patient, and you are rather here. And you see here that for RELAX 1, but more importantly, for RELAX 2, there is a direct relationship between the result of the study, the relative risk reduction, benefits of the drug, if you like, and the quality score of the country. The more the country has procedure, guidelines, and the more you are sure that the results will be positive. Now, if we look more at, let me go here. Now, if we try to look not only at the countryside, but at the site by himself, and you see that here is the country and here is the quality score of the centers, you see almost the same results. Again, it means that if your center is not managing patients following the guidelines, the risk is very high that even a positive drug, a drug that has benefit effect, the results could be even the opposite, because you see here that this drug can have even a harmful effect if a quality score is very low. And again, it may make sense in patients with a vasodilator that are getting a vasodilator agents, because if the patient is well treated, a vasodilator agent can have positive effect. However, if the patient is hypotensive, and if in addition you add some hypotensive drug, you can end up by doing some harm. And then you may say, but this is incredible. I mean, do you have other data to support this? The answer is yes. This is a trial I was participating on, and the sentence I'm going to show you is in the paper we published in New England a few years ago. This is a large trial comparing patients with ularitide, versus placebo. Now, concerning the whole cohort, the study was neutral. Then we said, okay, this is neutral. And then the statistician came and said, we have a safety concern here. There is one country where, for the large majority of the patient, they did not follow the inclusion-exclusion criteria properly, and they included patients that they should not have included. And it's written here in a post-hoc analysis that excluded the patients who had been identified before the database lock as having been ineligible for trial. Then we removed those patients coming from mostly one country, and suddenly the trial became positive with the benefit of the drug. Then you see how selecting the centers, selecting the countries is so important. Like, just to mention here the last sentence that was brought by Gary Cotter and Beth Davison, which is pharma and CRO should develop ways to measure site quality and even countries quality beyond simplistic measures, because right now they are just sending a questionnaire and say how many acute heart failure can you include every month. And this is really not the way to go. And I will show you in a minute how we did with several trials I was running. And in fact, we should come back to another metric, which is the metric of whether the centers and countries are following the guidelines. Now, in addition to selecting the centers, selecting the countries, which I hope I convinced you are an important issue, I'd like to go to another issue now, which is the issue of the number of patients we should include in the trial. Often we hear one expert in a meeting saying, oh, you only included 900 patients, 1,000 patients, 1,500 patients, but maybe, or very likely, if you have included more patients, you would have achieved a significativity, or you'd have more power, etc. And I'm going to show you how in heart failure we could describe an incredible effect that comes back, by the way, to the topic that I just mentioned earlier of including wrong centers and wrong countries. And this is the effects of dilution in the examination of new therapy. I'm going to take some time here for this slide. Then here what we are going to look is the association between the sample size of the placebo arm. Indeed, the placebo arm didn't get the treatment. Then the placebo arm tells you exactly the number of events for the selected population. And what we are going to do, we are going to see whether there is an association between the number of events in this placebo arm and the treatment effect, whether the effect that is giving to the active arm, whether this effect is higher or lower depending on the number of events in the placebo arm. And what we are going to see here is the 180-day all-cause mortality. On A and B, you will recognize chronic heart failure trials, and C and D, you are going to recognize the acute heart failure trials. And to be complete, what we did, we put those, every trial is a circle indeed, and the orange one are phase 2, and the blue one are phase 3. And what can we see? We can see that in chronic heart failure trials, if you increase the number of patients, or if you increase the sample size of the placebo arm, in fact, you have a little bit of difference. It's decreasing a little bit, but overall, the number of event, here on the y-axis, it's a number of event. We see that the number of event is very, very constant. Okay, and then now here we are going to see the hazard ratio of the therapies that were tested with the sample size, and we see that the effect of therapy does not change with the sample size. In acute heart failure is totally different. See here, first, the number of events on the y-axis and the number of patients included. And see here, it's rather incredibly clear. The more we include patients in acute heart failure, the placebo arm, and the less there is event. What does it mean? It means that the number of acute heart failure in the world, it's not high. There is a certain number of acute heart failure in many places. And when we would like to do a large trial, we go to centers who have no acute heart failure, and those centers are including patients maybe thinking that they are acute heart failure, but they are not acute heart failure. And clearly, you see that if we go higher than 500 to 1,000, clearly the patients that are included in trials are not the patients that we are expecting, or at least that we designed the trial for. And you see that the number of events is decreasing. And you see that in parallel here on D, here we have the hazard ratio. Indeed, when the hazard ratio is low, it's benefit. When the hazard ratio is high, it means harmful effect. And you see that the beneficial effect of the tested drugs, indeed, is reduced the larger is the trials. Then you see here in acute heart failure, and I can tell you this is also true for trials in critical care patients. The more you put patients, and the more you have a chance to have patients who do not have the inclusion exclusion criteria you think, and those patients will have, if you increase the size, will have a minimum of events, and indeed you will have a problem to find the difference between treated arm and untreated arm. Now, when we look on readmission rate, we are going to focus here again on C and D. Readmission rate, we found exactly the same thing for patients. The relationship here is clearly there. You see that the higher is the size of the placebo arm, the less we have events, and clearly we are including patients who even maybe do not have acute heart failure, and indeed the drug that is tested does not work. Now, in the other part of the spectrum, indeed, if we there is examples, and I'm showing you here Optima CC, where if the target is more to look on the safety issue, we can, with a minimum of patient, we can see whether there is safety issue. Now here, it's spectacular because it's really very small number of patients that could show a difference between epinephrine and norepinephrine. This paper was published in JACC a few years ago, where blindly the intensivists were giving epinephrine or norepinephrine to treat patients with cardiogenic shock, and they had all swan gas. Epinephrine, norepinephrine didn't show any difference in mean arterial pressure. However, epinephrine, adrenaline, had a higher cardiac index. This was transient for the first 12 hours, much higher heart rate, and no difference in stroke volume index. And in fact, the study was stopped by the Minister of Health because there was quickly signals toward a higher prevalence of refractory shock and a tendency for a higher survival rate than in fact, we included only 60 patients, and 60 patients were enough. Indeed, it was less than the plan, and the Minister of Health said, no, now we stop the use of epinephrine, and there is a meta-analysis that supported those results that we published almost the same month or 1 month later, showing that epinephrine had a 3-fold increase in mortality compared to the other ways. Now let's go to I think we got prognostic enrichment. We got that the idea is to select patients with a high risk of death or high risk to produce events. However, we saw all the danger to go from a prognostic enrichment way. There is a new way that is now more developed, predictive enrichment, and this select patients with a high likelihood of response to therapy. And the way I'm using it is by using a biomarker that is also biotarget. Then we can use a biomarker, and then we select patients who may answer best to a therapy. The biomarker that is most used in acute heart failure is indeed natriuretic peptide, and you can see that over years, here are the threshold of NT-proBNP. You see that before it was a huge threshold, and again, you can include so many patients which are different. And again, if you include so many phenotypes, this put a lot of noise and reduce the risk to have a positive signals if your drug has a beneficial effect. And you see now more and more, we have really a more thin area to include patients to make sure that the phenotype is a homogeneous phenotype. This is the paper we published the last year in septic shock. It is probably maybe one of the first biomarker-guided therapy in sepsis, and we used adrenomedulin. Adrenomedulin is released by many cells. It acts on smooth muscle cells to vasodilate, but it also acts on endothelial cells to keep vascular integrity. Now, in sepsis, we know that ADM is very, very high, and this has detrimental effects. And then a company, Adrenomed, produced an antibody that sticks to adrenomedulin and in fact, aspirate the adrenomedulin that is in the interstitium and put it inside the lumen of the vessels. In Adrenost, this is a septic shock trials. We try to do, as I told you, the biomarker-guided therapy. And what did we do? We did a predictive way, which means that we included only patients with a bioadrenomedulin level in plasma higher than 70 picogram per milliliter. And for those who needed to be treated, we gave adresuximab. This is an antibody that is modulating adrenomedulin. Then how did we do our study? This was 30 centers all around Europe. Then what we did is we went as early as possible in septic shock. Then the patient should have had norepinephrine less than 12 hours before the injection of the treated drug. Bioadrenomedulin, as I told you, should be higher than 70 picogram per milliliter. And then the patients were randomized to 3 groups: placebo arm, adresuximab 2 milligram per kilo, and adresuximab 4 milligram per kilo. And the patients were followed for 90 days for safety and efficacy. Here are the primary endpoint. We found no issue in safety for all the parameters that we looked on. And when we looked on organ dysfunction, we had a signal at 24 hours we could prevent, at least the drug seems to prevent any aggravation in organ dysfunction in the first 24 hours, and this benefit was still present in the following days. When one looks on the all-cause mortality, there was a very slight reduction, but clearly present, but very slight reduction in all-cause mortality. But I think you will see in the next bit what is interesting. Again, we gave this drug to the patient who had more than 70 picogram per milliliter of adrenomedulin. Then we were looking indeed for patients for whom the antibody could work. But maybe we forgot that some patients are very, very severe, maybe close to die, and then the antibody could not do something special. And then what we thought to do as a post-hoc analysis indeed is to try to see with a new biomarker named DPP3, the patients that are highly severe and that would die anyway, regardless to the way we would treat this patient. And I will show you in a minute how combining bioADM and DPP3, we can optimize even more the effect of the drug. DPP3 is in fact an enzyme that is inside the cells that is released when the cell dies, and you see in patients who are really in severe shock with cell death. And this DPP3 can have several harmful effects, and it was shown in preclinical studies to depress the heart. And you see here that if DPP3 is high in adrenos-1, then the patient will die more. And why I'm showing you here adrenos-1, because this is the trick that now we are using more and more. Before doing a trial, we decide who are the centers, and we don't send, we send no questionnaire to the centers. We don't ask them how many septic shock, etc. What we do is for 3 months, if they are motivated, we ask them to send us all the patients and putting all the parameters like an electronic CRF, all the parameters in their patient in septic shock. And then we would know exactly, without asking questionnaire, how many patients they have really per month, whether the patients that they are putting in the CRF are really the patients we would like to include in our trials. And we also show the motivation. And then adrenos-2 came after adrenos-1, and it was successful because we used the same network. Now to come back to DPP3, when we remove the patients with the DPP3 higher than 70, meaning the patients who have a high risk of death, we see a much larger difference in the improvement, and the improvement in organ dysfunction was really more clear, more striking, and indeed the mortality was also strikingly lower with adresuximab. And for all those reasons, in a few weeks now, we are going to start a following trial named Anchorage trial, where we are going to use DPP3 to include the patients. Then patients with elevated DPP3 will be excluded. We will use the same criteria for adrenomedulin. And then, as you see here, not only will treat patients very early, but also will use a double biomarker. Then it's a double biomarker guided therapy. And here we'll have a primary efficacy endpoint. This is 28 days all-cause mortality. Then here, by using a biomarker, we were going to try to enrich really as much as we can the patients that will be included in the trial. Maybe for the next few minutes, I'm going just to show you a concept of a new trial that is ongoing right now on post-discharge therapy. We are doing it for acute heart failure, but we are also submitting grants for critical care. What is the question? The question is for acute heart failure, for critical care, some patients are dying in the hospital, but many patients are dying after discharge. In the ICU, we have a cohort named Frog ICU that showed that 20% of the consecutive patients die in the ICU and 20% die in the following years. Then the idea is to see how in the following years we can prevent and limit the number of patients that die. And then we are thinking on giving oral therapy before their discharge. But I think I prefer we keep some time for a discussion. Then I come back here to my first slide. I hope I convince you that designing a trial is a multiple challenges. I insist on few points, which for me are really important points, is selecting the right patients that can generate events that are actionable by the therapy or the procedure. I hope I showed you how important it is to select centers and country, and that few centers and countries who are not who does not have a high quality of genuine therapy and do not follow the guidelines, this can neutralize the benefits of a drug. Selecting endpoints is very important. Again, it has to be actionable endpoint. I hope you understood the data I showed you on the effect of dilution I think it's very important to understand that. And again, an advice for critical care is to do a survey prior to a trial, to have really a group, a task force, selected centers and network that leads you to success. Thank you very much.
Thank you very much, Professor Mebazaa. Before jumping into detail of your talk, of your excellent talk, is we see my colleagues who are mainly working on intensive care units. There is different culture regarding including research into the everyday practice. You see that too, I'm sure. Intensive care specialists are sometimes reluctant and have a personal bias towards their experience versus what data shows. How do you implement a change of culture in the intensive care units you worked on to open the mind of those very experienced, very good doctors to incorporate that knowledge into the everyday practice?
I am also living with physicians who may say, I think many years ago, not today anymore, I did this for 30 years, then I am right. Okay. But now I think we have enough science, enough research, maybe not enough, but at least in the areas where there is clear evidence, now we need to use the new evidence. I mean, corticosteroids for COVID, I guess the day where the results came out, if the whole intensive care in the world, if every intensivist is not giving corticosteroids 6 milligram, and then data came saying it's maybe 12 milligram per kilo, I mean, I would say there is a problem there. Then it's not an issue of I believe, I don't believe. I mean, data is data. Concerning procedure, as I told you, I think what is nice in the Elizabeth trial that was accepted in JAMA, I think one of the reasons why they accepted it is also because we did this step-wedged approach, which I think it's not so much used in ICU or an emergency room. And it's a way, maybe, as you said earlier, to try to have some intensivist or emergency physician accept more to do a trial changing procedure. We say, okay, we do exactly like you do today, but when the clock rings, we do the new procedure. We all agree that we do it together for 6 months, and then we will wait for the results. I think it's a good way to test the procedure, and it's also a good way for the centers who are part of the trial to accept the result.
Okay. Jenny, would you start before I continue?
Yes, thank you. I have one question regarding this Elizabeth trial and the step-wedged cluster randomized trials. Do you observe any difference with respect to how long a respective ICU or emergency department follows the interventional protocol? I mean, does it have more experience if it applies the protocol longer?
It's a very good question. In fact, we had a period of 2 weeks. Then every 2 weeks, one emergency room had to switch from A to B. Every 2 weeks, then we had, at the beginning, we have 15, and then 14, and then 13, blah, blah, blah. Every 2 weeks, one center. Just because we are here in a session to see how to design trial, there is one issue with step-wedge that we had to face, and this is a seasonal rate of patients. If you have more patients with acute heart failure in the winter compared to the summer, then if your study is only 9 months, and this is what happened to us, then you may arrive at the end with less patients than what you did in the first procedure. What we did not test, and I think it's a very smart question, whether at the end this procedure, yeah, I'm sure we can find metrics to show that the center 15, the procedure didn't last more than the study, and maybe the center 1 is more. Yeah, I think it's a good idea. Yeah.
Could you elaborate again on this step-wedged cluster? So we know cluster randomized trials, which have their own advantages. But could you elaborate, on what this special design on step-wedged cluster randomized trials, what was so important for you, and what did you try to aim with this trial design?
Yeah, the step wedge is a very good technique for testing procedure. In fact, the reason why we did it, I went through that slide very quickly. It's because there was a study named GUIDED that was neutral. What is GUIDED? GUIDED is a trial where cardiologists had to increase the number of drugs for chronic heart failure patients based on NT-proBNP. This means that if NT-proBNP was not decreasing below a certain threshold, the cardiologists were increasing the dose, okay? And in fact, the two arms were running in parallel. Then some cardiologists told us, when the study was finished and was neutral, this was a big surprise, but they told us exactly what I told you. Tuesday morning, they were an outpatient center, and they had in box A, one patient that was the arm where they shouldn't do anything because they did not know the level of NT-proBNP. And in an arm in the box B, they had the patient in the other arm where they knew the NT-proBNP and they had to increase the drug. And they said, very quickly, even the patient where they did not know the NT-proBNP, they were also increasing the level of the drugs. And in one brain cannot the same morning do different things. And then knowing GUIDED and knowing the results of GUIDED and knowing the fact that when you have a procedure, it's really difficult to have at the same time all the nurses, all the physician, everybody doing two different things, which is impossible because even the nurse would not understand what's happening in the unit. And then we decided to go to the step wedge. Now the step wedge has also another issue, is you need to include 20 to 30% more patients than two arms for some mathematical reasons. But the big advantage is that you keep doing exactly what you are doing. We just notify the events. And one day, in fact, we stop. In fact, we were doing 2 weeks of teaching. Then we had CRAs going to that emergency room. And for 2 weeks, they were teaching a new procedure to everybody, day, night, medical students, nurses, physicians, etc. And after 2 weeks, clack, we start the new system.
Okay, very good. And you mentioned that the quality of data is key to have good results.
Even the quality, I think what is maybe novel for you is the quality of the management of the patient. Mm-hmm. And again, I think Janine can, she's an interventional cardiologist, she understands this very well. If in a center you try to treat acute heart failure patients, you have a protocol and you give a treatment A versus treatment B. If when the patient has an acute myocardial infarction, he doesn't go to the cath lab. And if the acute myocardial infarction, you have 3 in one arm and 3 on the other arm, and 3 are not doing well, by definition, you kill any benefits of the drug. You see, it's as easy as that. If the patient leaves the ICU with an acute heart failure, you don't give him beta blocker, ACE inhibitor, and he leaves with nothing, then whether you give a good drug or not a good drug, at the end, they will have the same outcome. Then, the standard of care has to be of a high quality before testing a new drug. If the standard of care is bad, the outcome is going to be bad and the signal cannot appear. And this is what those data, for me, it was, when I saw this, I was just crying. It's incredible because I can tell you every day you have CRO who are coming telling you, oh, I have that country, I can give you 20 centers, the other country, I can give you 30 centers. Please, I didn't say you should not go there, but find ways to check who are those centers, find way to find metrics to check the quality of care. I'm even not talking about quality of ECRF, I'm talking about quality of care.
You showed that there is a country quality score and a site quality score on one of your slides. What were the key parameters assessed for?
Easy is as simple as, I know you're not going to believe this, as simple as giving diuretics in patients just yes or no diuretics. Okay, this is one of the parameters. Some centers do not give diuretics. Then diuretics, it is beta blocker if the patient has a chronic heart failure or hypertension. 4 or 5 parameters. Nothing. I tell you, no rocket science. And you clearly see a huge difference.
I like your approach of trying to find out in which centers you find or you can find motivated colleagues in order to make a little bit of selection of centers. On the other hand, sometimes 1 or 2 motivated colleagues are not enough and are not representative for the rest of the center. So are there any other approaches to find out which centers are performing or at least have the quality standards you want to have?
In fact, what we are doing more and more is in fact, we listen to the CROs and we say, okay, you know 100 centers, okay, give us the 100 centers. But we don't send them a questionnaire. Questionnaire is too easy. The guy, and I can tell you the questionnaire since 30 years, I never saw a questionnaire where the guy give a number that is below the number he included. Never. It's always 20% until 200% more. Then well, okay, then come on, I should stop them. Then I say, okay, you give me the centers, and I ask either the institution if the grant is paid by the Minister of Health or the company. I say, give me a little bit of money, not so much. It's 50,000 euros, not much. I do an ECRF, and you see also the motivation. If the guy, you say for 3 months, you include all the patients, it shows a motivation. It shows that resident students are involved if they have CRA, the quality of the data, the way they manage. You see, it's like it doesn't have to be more than 1 page. One simple, just simple.
Do you reimburse the trial site for this?
The centers among the 100, if you select 20 or 20, I'm sure you select the best.
Do you reimburse the trial sites for entering this pre-screening form?
In fact, I think we gave a little bit of money, but the reward is to be part of the trial.
Okay. I have one question regarding you said, we have to aim for a homogeneous phenotype to decrease the variance to see the effect. But so far, we were unlucky to have reached that on a proper base on a non-post-hoc analysis. Maybe that's because acute heart failure is so different, not in the phenotype, but in the etiology. It's so different. Maybe that doesn't make sense to perform trials in acute heart failure because they're so different. Why am I wrong when I say this?
No, you are not wrong. You are right. And this reason why I wrote an editorial I thought to show you, but I think I gave you already enough information. I think we should stop first thinking that giving a drug IV for 48 hours can change survival at 28 days or 90 days. And you know why the companies are giving drug IV only for 48 hours? Do you have an idea? All the trials IV, it's 48 hours. You know why? Because there are data that shows that the patient who's improving dyspnea will not keep the IV line more than 48 hours. He will remove it. We are basing billions, because all the studies are, it's more than billions, just because the IV line, and in our daily practice, there is no heart failure patient, you can keep the IV line more 48 hours. The guy will yell and he'll leave the hospital. Then I said, okay, we should stop that. And indeed, there are a lot of patients who die in the hospital, but there are even more that are readmitted and die after the hospital. And this is reason why I am putting more emphasis on post-discharge, because post-discharge is a more homogeneous population, because those who will die in the hospital, those who are treated or untreated or not well treated because of their cause of decompensation, everything will stay in the hospital. And after the hospital, there is still huge room to improve those patients. And I think at least today we should focus on those ones.
Mm. You showed in one of your data a trial, I think, which is planned, where you have DV3 and ADM as inclusion criterion.
Yeah, Anchorage trial, yeah.
And
in septic shock.
Which sets the question, for measuring both parameters, you need either a central lab or the lab, the point of care lab, or the lab on site should be able to do that. How do you manage it, especially
point of care, unless it's not possible. The first Adrenos 2 trial was done with a point of care that needed 2 hours, and in fact in Paris region we had a high number of patients recruited in Paris, and the 9 ICUs in Paris, my ICU was measuring for all the 9 to be more homogeneous than the samples were coming with a taxi, and after 2 hours we are giving the results. And the company improved the technology, and it will be either a single or 2 device, but we will have the numbers within less than half an hour, 20 minutes, I would say, unless it's not possible indeed.
So in your budget calculation, you have to include providing the sites with a point of care device too, right?
Yeah, the company is giving it, then you don't need to put it on the budget. Yeah, probably you need to put the budget of the research nurse that will do it. Probably you will plan, let's say, an hour max, but the device is giving, yeah. Perfect.
Thank you very much. I have one last question, not asking you not in the role of a trialist, but the role of a guideline author. When you see the heterogeneity in outcome between sites and between countries, how do you incorporate that when you're considering and when you're looking at the data into authoring the guidelines?
In fact, when we were writing the guidelines, I would say one of my main tasks is to think how those guidelines can be used in any part of the world. I think this is important, and it's unfair for chronic heart failure. Indeed, there are new medications, but there are also classical medications that cost nothing, and it's really that they are not giving to the patient just because the GP have no knowledge or the cardiologists are too busy. There are too few cardiologists all around the world, and really every time with Marco Metra and Teresa McDonagh, when we did a lot of algorithm to try to really simplify as much as we can some of the very important recommendations. And I can tell you, for chronic heart failure, it costs nothing today to save, I would say, 20 to 50% of chronic heart failure patients. And this is also true for acute heart failure. Then it's easy, simple, and yeah. Now the question is more how to implement those guidelines until the last village of every country. But the data are there, and it does not cost so much money.
Thank you very much. I would love to draw the attention of the audience also to the 3CT, the Critical Care Clinical Trialist Workshop, which you host and which you organize in Paris, and which had to be taking place online, as far as I understand. Of course, like a lot of things.
In fact, it's Washington. It's in Washington, D.C. at the French Embassy. And it's there because we can have really directly the regulators, European, American, the NIH also, because we love to listen to the NIH and their new trials. And I can tell you, it's an incredible opportunity to have European and Americans showing their data. And I think Janine can witness that Europeans are very well positioned in critical care in cardiogenic shock. I would say Europe is really a leader between Germany, indeed, France, You may have seen the last trials coming out in the top journal, and critical also. But some other areas, probably like the lung, the Americans are ahead. But I can tell you overall, over the 2 or 3 days, it's incredible to see how it's great to learn from each other.
Professor Mebazaa, we learned a lot. Dear Janine, do you have further remarks?
No, thank you. Thank you very much, Alexandre.
Thank you, Janine.
Thank you very much. We learned a lot. We appreciate your dedication for education very, very much, Professor. And I hope to see you soon again.
Thank you, Javid.
Thank you very much.
Bye.